Hello, my name is Amber, and I'm going to review preeclampsia with you today and update you on protocols for treatment. Let's first talk about patients that could present to your unit with higher risk factors than others. It is difficult to predict who will experience preeclampsia during their pregnancy due to the unknown nature of the syndrome, but certain risk factors involved could increase a woman's chance. Patients who have chronic hypertension, are at advanced age, have chronic renal disease, are obese, have vascular disease, are young at age less than 17 years old, have a personal or family history of preeclampsia, have diabetes, used in vitro fertilization to become pregnant, nulliparity, multifetal pregnancy, or have lupus are some of the higher risks for developing preeclampsia than other patients. The exact etiology of preeclampsia is unknown, but let's talk about what could be possible causes for preeclampsia. Studies are suggesting that the placenta can be the cause of preeclampsia. Genetic abnormalities, poor uterus perfusion, and an abnormally functioning placenta are all probable causes of preeclampsia. So, what exactly is happening to the body during preeclampsia? We have three key factors in preeclampsia: the spiral arteries, the placenta, and mother's body, specifically the endothelial cells. The spiral arteries are found in the uterus and they play a big role in supporting the pregnancy. The trophoblasts that bed into the uterus and need good blood flow in the placenta through the spiral arteries. At 20 weeks gestation, these vessels will widen for more blood flow to nourish the baby. In preeclampsia, the vessels do not widen like they are supposed to and therefore cause vasoconstriction. Vasoconstriction of the vessels in the placenta and the mother's body will cause the blood pressure to rise. Picture a garden hose and you putting your thumb over the opening, and the pressure of the water increases and comes out with more force. This is what is happening inside the vessels with increased blood pressure. With decreased blood flow to the placenta, it will become ischemic and baby will not be able to grow and develop properly. When the placenta experiences ischemia, it will release toxic substances into the endothelial cells in the mother's body and become damaged. Endothelial cells line the inside of the blood vessels throughout the whole body. They line the organs like the kidneys, the brain, and the liver. They control the tone of the blood vessel that causes vasoconstriction and cause high blood pressure in the patient. These endothelial cells that are damaged also allow fluid to leak due to less permeability of the blood vessels. The kidneys, particularly the glomerulars, are what filter out your blood. Usually, they do not let large molecules out. Protein is one of the large molecules that is allowed to leak out of the vessels when the endothelial cells are damaged. Protein regulates oncotic pressure, and when protein is being leaked out of the vessels, water is going to follow. So protein is going to leave the blood and it is going to go into the urine. The kidneys are not functioning like they should. There are vasospasms happening and decreasing the perfusion of the kidneys. Water is leaving the blood throughout the body, and so it is letting the blood volume drop. When blood volume drops, blood flow cannot effectively reach organs in the body, so the kidneys are not functioning as they should. Kidneys usually are able to regulate uric acid, and they are no longer to do this. So uric acid are going to increase, which is a waste product. Creatinine levels are going to rise as well, and urinary output is going to decrease because the kidneys are not functioning like they should. Edema is going to happen because the permeability problem in the vessels and water leaking into the interstitial tissues. You will notice puffiness in the face and around the eyes and edema in the extremities. The lungs can be affected because fluid is getting trapped in her lungs, causing pulmonary edema, and so she could complain of shortness of breath. Edema also happens in the brain, causing cerebral edema. Remember, there are endothelial cells in the head that are also leaking. This is where symptoms can be severe and start turning into eclampsia. When there is swelling in the brain, you will see the CNS symptoms of severe headaches, vision changes, hyperreflexia. We also want to be checking those deep tendon reflexes and checking for clonus in the ankles. When they are experiencing these symptoms, They are at high risk for the convulsion episodes. The liver is also going to be damaged, so the liver enzymes are going to increase. So you're wanting to look at the ALT and the AST. The patient could complain of upper right quadrant pain. Diagnosing a patient with preeclampsia comes down to lab work and objective information found in the physical assessment. The patient must have increased blood pressure, protein in the urine, signs of organ injury of either the brain, kidneys, or liver, and the patient must be over 20 weeks to be diagnosed with preeclampsia. Accurate blood pressure readings are important in treatment. Make sure that the right size cuff is on the patient. Too small will give an artificially high number, and too large of a cuff will give an artificially low number. The patient should be supine in a semi-reclining position or in a sitting position without their legs crossed. There needs to be at least 2 separate readings of increased blood pressure and diastolic number above 90 and systolic above 140. Vitamin C, vitamin D, or calcium are not effective at stopping the development of adverse effects in preeclampsia. The only way to treat preeclampsia is the delivery of the placenta. Immediate release oral nifedipine may be given if IV access is not available. Magnesium sulfate is not used as a hypertensive agent, but used for seizure prophylaxis. Be prepared to give celestone to your patient if the gestational age is under 34 weeks. Severe hypertension is classified if the systolic pressure is equal to or above 160 and the diastolic pressure is equal to or above 110. The degree of systolic hypertension may be the most important predictor of cerebral injury and infarction in the mother. Administration of IV labetalol for severe hypertension guidelines is to give 20 milligrams of IV labetalol and check the blood pressure after 20 minutes. If the blood pressure is still elevated with systolic at or above 160 and diastolic at or above 110, give 40 milligrams of labetalol IV. If blood pressure is still elevated after 20 minutes, give 80 milligrams of labetalol IV. The total amount of labetalol given in a 24-hour period should not exceed 300 milligrams. If blood pressure is still elevated after giving 80 milligrams of labetalol IV, give 10 milligrams of hydralazine IV. If you start the protocol by giving 10 milligrams hydralazine IV, check the blood pressure after 20 minutes. If the blood pressure is still equal to or above 160 over 110, give another 10 milligrams of hydralazine IV. Wait another 20 minutes, and if the blood pressure is still out of range, give 20 milligrams of hydralazine IV. If your patient is still experiencing severe hypertension, give 40 milligrams of labetalol IV. If you do not have any IV access and you are needing to give your patient immediate care for the severe hypertension readings, immediate release nifedipine 10 milligrams should be given. Recheck the blood pressure after 20 minutes, and if the systolic or diastolic pressure is out of range, give 20 milligrams of immediate release nifedipine. Recheck the patient's blood pressure after 20 minutes, and if still elevated, give above 160 or 110, give another 20 milligrams of immediate release nifedipine. You need to be attempting to obtain IV access during this time, and if you recheck the blood pressure after 20 minutes after giving the second dose of 20 milligrams of nifedipine, and you have IV access, give 20 milligrams of labetalol IV. Once the blood pressure is below the threshold, continue to monitor blood pressure every 20 minutes for an hour, and if the blood pressure is still below the threshold, monitor every 30 minutes for an hour, and then hourly. Start with labetalol protocol if possible because the antepartum maximum dose of hydralazine in a 24-hour period is only 20 milligrams. There is no maximum amount for those not pregnant. Do not give labetalol to asthmatics. Magnesium should be given with caution in patients with acute or chronic renal disease. When giving magnesium for seizure prophylaxis in antepartum patients, give a 6-gram loading dose and 2 grams an hour continuously. If giving magnesium to postpartum patients, give a 4-gram loading dose and then 2 grams an hour continuously.